Good morning. We're going to start this morning's plenary session. Hope everybody had a restful evening last night. This morning, the focus is on diabetes. I think it's important. We have three distinguished speakers this morning. I'm finding the diabetic world more and more complicated as far as I'm concerned. It's not just insulin and metformin anymore. I've heard about other medications that my colleagues are using, and on the stroke units, we're finding so many of our patients with diabetes. So it's a very important topic. It leads to all vascular complications, and we need to know how to manage it better. This morning we have three speakers. We will have plenary sessions followed by a question and answer period afterwards. Our first speaker this morning, I'm very pleased to introduce, is Dr. Hertzel Gerstein, who is a professor at McMaster University in Hamilton Health Sciences, where he holds the Population Health Research Chair in Diabetes and is director of the Division of Endocrinology and Metabolism. He's the director of the Diabetes Care and Research Program and deputy director of the Population Research Institute. Dr. Gerstein's research has been published in over 350 papers, spans 50 countries, and has been funded by NIH, the Canadian Institutes of Health Research, the Heart and Stroke Foundation of Canada, the Canadian Diabetes Association, and the pharmaceutical industry. His research focuses on the prevention and therapy of diabetes and many consequences, the relationship between dysglycemia, a term he coined in 1995, cardiovascular outcomes, cognitive impairment, other diabetes-related chronic consequences, and new diabetes, strategies for type 2 diabetes remission, and novel biomarkers for cardiovascular disease and diabetes, and the biological basis of glucose-related health consequences. In 2016, he produced and distributed a music video to mitigate the impact of diabetes on affected people and their families. And in 2012, he received the Canadian Diabetes Association Lifetime Achievement Award. I will have to watch the video. No. Dr. Gerstein.
Yes, you should definitely see the music video. It's excellent. Thank you very much. It's a pleasure to be here, and I always enjoy speaking to my colleagues from a cardiovascular perspective and an endocrine perspective. And I can tell you that diabetes and cardiovascular disease have been really close partners for the last 30 years, and more so in the last 5 or 10. So I'm going to discuss this topic, a menu of glucose-lowering agents and their cardiovascular effects. And I'm going to focus, in fact, almost exclusively focus on what we know from well-designed, level 1, large, randomized controlled trials, because this is the best evidence that informs the title on this slide. These are the list of companies that I've had the pleasure to work with to help improve the lives of our patients with diabetes and cardiovascular disease and reduce their morbidity and mortality, actually. Every recommendation I'm going to make is based on the evidence within randomized trials, and if I make any comments about off-label use, I will certainly point that out. And so here are the learning objectives for this presentation. At the end of my session, hopefully you will understand and be able to classify to some extent the pharmacologic approaches to glucose lowering, what we know about the cardiovascular effects of these glucose-lowering drugs, and perhaps start to think about tailoring these drugs to your individual patients. And if you're not prescribing them, at least be informed in terms of how they're being used by your colleagues that are prescribing them, who are prescribing them. So here's the outline of my presentation. Let's just first introduce the topic. Wes said at the beginning that he's seeing lots of patients with diabetes. Well, this is a meeting of the Heart and Stroke Foundation, and I tell you that you're all seeing lots of patients with diabetes. 2 out of 3 patients in any CCU at any one time either have diabetes or prediabetes. And the same thing would apply to a stroke unit. So this is dysglycemia, metabolic abnormalities related to glucose are ubiquitous, and they're very common in a cardiovascular context. So you're all seeing them. So people with diabetes are at higher risk of cardiovascular outcomes than people without diabetes. Here is a meta-analysis already a few years old now, and this is about 10 years old, but it still holds today. So diabetes is an independent risk factor after adjusting for anything else for cardiovascular events. It's an independent risk factor for coronary heart disease, for cerebrovascular disease, ischemic stroke, even hemorrhagic stroke, and peripheral vascular disease, and it's about twofold higher risk compared to people without diabetes. And not only is it a risk factor for things that are related to the arteries, but it is also a risk factor for the muscle. And so we know that diabetes is a clearly important risk factor for heart failure. And this is both heart failure with preserved ejection fraction and heart failure with a reduced ejection fraction. So here's now what's become a fairly famous slide, about 8 years old now, or 10 years old. If you look at the cumulative incidence of heart failure hospitalization or death in people without diabetes and a preserved ejection fraction, which you see on the over there, on the bottom, and then people with diabetes and a preserved ejection fraction, it's clearly about double the risk, and it goes all over with time, and you can see very clearly. And then if you look at reduced ejection fraction, you see the exact same thing. So a person without diabetes and reduced ejection fraction has the same mortality as a person with diabetes and preserved ejection fraction, actually. But again, the ratio between people with diabetes is double the risk in people without diabetes, regardless of their ejection fraction. And there has been controversy over the years, going back to when I was in medical school, which was well into the last century, as to whether there was such a thing as a diabetic cardiomyopathy. There indeed is a diabetes cardiomyopathy, and perhaps other people will talk about that, but clearly we know that muscle problems are part and parcel of diabetes. Now, I talked about diabetes being an important risk factor for cardiovascular disease, and it's an important risk factor for death. So here's data from 128,000 deaths and about 700,000 people followed in 91 cohorts for a median of 13 years of follow-up. And they looked at the risk of death in people without diabetes and people without previous MI or stroke. And if you look if you look in the bottom, and I'll just use the pointer. Oh, okay, one sec. Let me just, got to be careful with this mouse here. Good. If you look there, that's people without diabetes and no MI or stroke. The mortality rate is 0.7% per year, 6.8 per 1,000 person years, 0.7% per year. If you look right above that, people with diabetes, it's double, 1.6% per year. And you look right about that, it's the same as the mortality in somebody who's had a previous stroke, and it's the same as the mortality in somebody who's had a previous MI, about 1.6% per year. And the hazard ratio, as you see, diabetes alone or stroke alone or MI alone, over there, is about 2 compared to no diabetes. Now, people say, okay, and this is adjusted to age 60, and this is so pretty broadly accepted. And people say, oh, yeah, well, that's, okay, I buy that, that's serious. People actually, interestingly, we all have different perceptions of seriousness depending on the disease we think about and that we're comfortable with. So how serious is that compared to other diseases? And I'm going to show you this as an example. So that is the mortality of people with diabetes age 60, and I showed you people with MI age 60. What is the mortality of a woman diagnosed with breast cancer? Now, everybody hears the word cancer and, oh my God, cancer's bad. Well, here's the mortality of breast cancer in the United States. If you look at all comers, all stages of breast cancer, mortality, about 2% per year. Pretty close to the risk of death if you have diabetes or the risk of death if you've had a previous MI. And if you look at, 62% of breast cancers are localized cancer, it's about a quarter the risk of death compared to if you have diabetes. So clearly, cancer is a bad prognosis. But the point is that if you think cancer is a bad prognosis, diabetes is certainly a bad prognosis. And so is myocardial infarction, and so is other things. So I think it's really important to not minimize the problem and the morbidity and the mortality of diabetes and dysglycemia. Okay, what is the link of the relationship between bad things and glucose levels? So this is one slide I'm going to show you. Here's a lovely Swedish analysis of their database, which is a large registry of 500,000 people with diabetes and 2 million matched controls. Followed within the registry, because in Sweden you get a number when you're born and they can link it to your whole life. So they can actually do these very nice little registries linking risks of hospitalizations and other things together. So compared people with diabetes to people without diabetes with respect to their hazard of dying, and what they've done is they've stratified it according to age. So, and looked at it according to age and what the A1C is. And this shows you that your A1C level, the higher the A1C level, the higher the risk of diabetes. So if you look here, so up there, that's people less than or equal to 55, A1C less than or equal to 6.9% in people with diabetes, still about twice the risk of death compared to no diabetes. And the higher the A1C, the higher the risk. And it doesn't matter what age it is. So even less than or equal to 55, the higher the A1C, the higher the risk of death. And if you go down that slide, even greater than or equal to 75, the higher the risk, the higher the A1C, the higher the risk of death. Why does it attenuate towards 1 the older you get? That's easy. The older you get, the more you're being killed from other things. So there's competing things that are killing you when you get older. But the point of the slide is, it doesn't matter how old you are, hyperglycemia increases your risk of death more than normal glycemia in people with diabetes compared to out. And in fact, when you look at these slides in other populations, it doesn't even matter whether you're called diabetes or not. The higher the A1C, the higher the risk of outcomes. So, we've established so far that diabetes is a clear risk factor for cardiovascular disease. It's a risk factor for mortality, and it's not a trivial risk. It's a serious, major risk. Absolute risk is high. Does glucose lowering reduce the cardiovascular consequences of diabetes? Diabetes, by definition, is a disease of an elevated glucose level. If your glucose is normal, you don't have diabetes. So it raises the question, well, if glucose is a strong risk factor for diabetes, and a strong risk factor for mortality in people with diabetes, and it is, and I can also tell you that there are 3 large, well-done Mendelian randomization studies showing that glucose causes cardiovascular disease. So if that's true, then glucose lowering should reduce cardiovascular disease. Well, the answer is messy. So with type 1 diabetes, the answer is very simple and clear. The answer is yes. In fact, we know with type 1 diabetes that tight glucose control, more versus less intense glucose lowering in randomized controlled trial, large trial, reduces the risk of the 20-year risk of death, mortality, and cardiovascular events. There's no question. Now, that was based on a trial done in people of average age 20, 25. So there were very few other things that were killing them. But when we look at the studies in type 2 diabetes that were all in people average age 66, 67, 80, 70, et cetera, around there, the answer is a lot messier. So some of the trials show a reduction, other ones show no reduction. One trial showed an increased mortality. So the answer to the question is that it's not clear. If you meta-analyze these all together, there's a pretty clear signal on reducing ischemic heart disease very modestly, in the order of 10 to 15%. But the answer is a messy one, and it probably is like the story of lipid lowering before there were statins. Is that until recently there have not been really effective ways of simply lowering glucose levels, so that's complicated the problem. But I'm going to tell you the answer is messy with glucose lowering for type 2 diabetes, especially after 60 or 70. So really, our goal for glucose lowering based on strong evidence is we clearly know we reduce eye disease, we really know we reduce kidney disease, and we look at other things for cardiovascular disease at this point in time. Okay. What about the actual glucose-lowering drugs? So stepping a little bit back from whether we lower glucose levels a lot, do the drugs that we use to lower glucose levels have intrinsic cardioprotective effects to them? And we have been blessed because of pressure that we and others have put on the world, but there have now been a plethora of large randomized controlled trials that have explicitly asked and answered that question. So if you're interested in a nice summary of this, this was an editorial that we published early this year. 2018, it was a group of people from around the world got together and talked about cardiovascular outcomes trials and type 2 diabetes. And this is a figure from the trial showing just a subset of a figure from this paper showing a subset of all of the large, well and adequately powered cardiovascular outcomes trials that have been conducted in this space over the last 10 years, or 15 years, and some of them are still ongoing right now. Well, I'm just going to summarize all that for you, the results of what we know in the remaining part of my presentation. So here is the list of the glucose-lowering drug classes or glucose-lowering drug categories that is currently available on the Earth in 2018. So at some place on the Earth, there are representatives of these classes of drugs are available. I'm just going to sidetrack for a minute to say, by the way, there is really no such thing as a drug class. FDA does not accept the concept of class, and neither do other people, but we are all clinicians, and in fact, it is a convenient mnemonic for us to group things together, but we always need to be a little cautious because different representatives of a class may have different effects. So when I say class, just put quotations around it saying, yes, we know there's no class, but we have to have short form ways of thinking. So let's start off with sulfonylureas. What is the effect of sulfonylureas on cardiovascular outcomes? The answer is, we don't know, because there have not been a dedicated cardiovascular outcomes trial that has randomized people to sulfonylurea versus placebo and followed them for the development of cardiovascular disease. Having said that, we will probably know in 8 months, because there are actually 2 trials that will together tell us the answer. There was one trial of a sulfonylurea versus a DPP4 inhibitor called the Carolina trial, or the Carmelina trial. Which one is the one? The Carmelina trial. That was just published, and that showed neutrality, that linagliptin is equal to a sulfonylurea. And there's another trial called the Carolina trial that's going to be published in a few months, which is linagliptin versus placebo. So if linagliptin versus placebo is neutral, and we know linagliptin versus sulfonylurea is neutral in cardiovascular outcomes, we will know that sulfonylureas are neutral. If, on the other hand, linagliptin versus placebo is superior, then we'll know that sulfonylureas are also cardioprotective. So, and if linagliptin versus placebo is inferior, then we'll know that sulfonylureas are harmful. So, as of today, we do not know. If there are any biologists in the room, they might put up their hand and say, wait a second, we have all this animal data of sulfonylureas and receptors in the heart. That's very nice. I can show you lots of animal data to prove anything I want. You've got to do the studies in humans, and you really have to have the answers clearly from large trials. So that's where we are with sulfonylureas, notwithstanding the fact that they are one of the commonest classes of drugs used today. So that's, at least in the world, maybe not in Canada as much. What about the second drug, metformin? Now, metformin has this beautiful halo around it that as being such a wonderful cardioprotective drug. Well, I'm going to tell you right now, the evidence for cardioprotection for metformin does not pass muster using today's standards. It was one incidental analysis of the United Kingdom prospective diabetes study in which 342 people were allocated to metformin, and there was a 40% reduction in mortality. But it was a nice hypothesis to be generated. The most important thing that study did, the UK PDS study did for metformin, was take metformin from being a drug that was eschewed in the medical practice. Those of you who are my age remember that people didn't prescribe metformin because it caused all these, quote, bad things, which we now know it doesn't cause, and it became a very commonly used drug. But metformin is a good drug. It prevents diabetes, and it clearly does in lots of trials, but whether it is truly cardioprotective or not, we really don't know, and so that's where that stands right now. Acarbose. Acarbose is a drug which slows gastric emptying, which slows absorption, pardon me, it doesn't slow gastric emptying. It slows absorption of glucose from the gut. And there has been a large cardiovascular outcomes trial done in people with pre-diabetes in China who had IGT. So done in people with impaired glucose tolerance who had actually coronary heart disease. They all had angina or acute coronary syndrome, followed for about 5 years, acarbose versus placebo. Prevents diabetes in those people, neutral on cardiovascular outcomes, neutral. What about meglitinides? Neteglinide and repaglinide, these are not commonly used right now in Canada. Neteglinide, they're short-acting insulin-secreting drugs from the pancreas. There was actually a trial of 11,000 people with pre-diabetes, randomized to neteglinide versus placebo, neutral on cardiovascular outcomes. Okay, what about insulin? Insulin is a drug that's been available to treat diabetes since 1922. And between 1922 and 2012, for 90 years, there was tons of controversy that, oh, insulin is not good for your heart, or insulin is good for your heart. And there was a lot of argument back and forth with people using animal data to make a point, or other data, or epidemiologic data. How do you resolve the question? You do a large, well-designed, randomized controlled trial. And one was done, published in 2012. 12,500 people were randomized to one injection of insulin versus no insulin. Around the world, and 60% of them had previous CVD, mean age was 64, and they were followed for 6.2 years on a median follow-up, so half were followed for more than 6 years for the occurrence of MI or stroke or CV death or heart failure or revascularization. And that was, and at the end of the day, the vast majority of people randomized to insulin stayed on insulin. The vast didn't. We're on no insulin at the end of the study. So what is the effect of insulin in a randomized large trial on cardiovascular outcomes? Neutral, neutral, neutral. The first co-primary was MACE outcome, MI, stroke, CV death. The second one added heart failure and revascularization. Neutral. Neutral on death, neutral on each of the components of the outcomes. What about heart failure? So most cardiologists say, oh, don't give insulin, heart failure, it causes fluid retention and heart failure. Well, let's look at what it did in a trial, right? And the problem with all the observational anecdotal evidence is people prescribe insulin when nothing else works and when nothing else can be given because of contraindications. But in this thing, we did a trial. So we looked at the effect of insulin on heart failure, and here it is in that trial, in the ORIGIN trial, the risk of death in people on insulin versus no insulin, neutral. First heart failure, hospitalization, or death, neutral. First heart failure hospitalization, even if you account for the fact that some people died before they had a heart failure, again, neutral. And then we looked at recurrent heart failure hospitalization. If anything, it's on the line towards benefit, not harm. So this is recurrent heart failure hospitalizations in the ORIGIN trial, insulin versus no insulin. It depends, analyzing recurrent events is controversial. What's the best model to use? But we used 4 different models. And some of them show benefits, some of them show neutrality. But none of them show that insulin increases any heart failure hospitalization. So the point about this is, and other outcomes in the ORIGIN trial, all neutral on cardiovascular events, and cancers were neutral, etc. So the point of this slide is to say, when you use insulin in people with diabetes, use it without fear of causing any consequence except hypoglycemia. Hypoglycemia is the only adverse effect of insulin. And weight gain in this trial was about 1 kilogram after 7 years more than the people who were in the control group. So now, in fact, that trial was so relevant to care because of the large numbers of people with diabetes in the world right now, 1 in 10 adults, that FDA told Novo Nordisk, said, well, if you want to market your drug called Degludec, you have to show that it's as safe as glargine with respect to cardiovascular outcomes. So they did a trial. They did 7,000 people randomized to another long-acting insulin, Degludec, which is called Tresiba, glargine is called Lantus. Degludec versus glargine followed for 2 years, and the effect on cardiovascular outcomes was equal. So basically, there was less hypoglycemia, but no difference in cardiovascular outcomes. So 2 long-acting modern insulins neutral on cardiovascular events. Good to know when you're prescribing insulin, you're not hurting people. Thiazolidinediones. Now here's a good political, bedtime story, but we're not going to talk about that. TZDs, pioglitazone, rosiglitazone, they used to be very commonly used until the politics went crazy, and it was politics. And in the end, the politics destroyed these drugs. But in fact, what is objectively the effect on cardiovascular events? There was an NIH study that was published 2 years ago called the IRIS study. 4,000 people with pre-diabetes, actually only 76% of them were pre-diabetes, randomized to pio versus placebo, followed for 5 years. And a lot of events in this trial. There you go, 24% reduction in MACE outcomes compared to placebo. And in the end, the only adverse effect was more fractures. And we know that there are more fractures with this drug. Okay, next class, DPP4 inhibitors. These are very commonly used drugs. They have very few side effects, and they're ubiquitous. Together with metformin, they lower glucose levels a nice amount, and they work by prolonging the action of a hormone in our body called glucagon-like peptide 1. So they prolong its action in the body. And so sitagliptin is a commonly used one, linagliptin, etc. There have been five large outcomes, cardiovascular outcomes trials of DPP4 inhibitors, different ones, sitagliptin, alogliptin, linagliptin, saxagliptin, I don't know if I'm missing one, versus placebo, neutral. All of them totally neutral in cardiovascular events. In acute coronary syndrome patients, in ambulatory patients with previous CVD, and in ambulatory patients without CVD, all of them neutral on cardiovascular outcomes. Next class, GLP-1 receptor agonists. Well, these drugs have been around for about 5 years now. They're injectable. You're giving this hormone, which is called an incretin, glucagon-like peptide 1. These are not the native GLP-1. They're agonists. They last longer in the blood than GLP-1 does. And they work to suppress appetite, reduce gastric emptying, and increase secretion from the pancreas of insulin only when the glucose is high. So they don't cause hypoglycemia. They don't make the pancreas make insulin when the glucose is normal. And these drugs have been tested in a number of trials, and I'm going to show you the meta-analysis of these trials. So here's 4 of the trials when they were meta-analyzed, and you see all 4, they were done in either acute coronary syndrome or ambulatory patients with CVD or with risk factors. And when you meta-analyze them on MACE, which is MI, stroke, or CV death, you see a 10% reduction. Total mortality, there's a 12% reduction. CV death alone, there's a 13% reduction. I'm just going to get the meta-analyzed number. MI alone, there was no clear meta-analyzed benefit. Stroke alone, there was about a 25% reduction just on the line of neutrality, on the line of significance when you actually meta-analyze all 4 of them. And then the side effects, hypoglycemia, as I said, they don't cause hypoglycemia. Pancreatitis was a concern, doesn't seem to have materialized, and neither did cancer materialize with these drugs. There's been another, that was 4. Now, since those 4 were meta-analyzed, another one was published of another injectable, weekly injectable, showing also a benefit, 22% reduction in cardiovascular outcomes. And that's the 5th one. And then 2 more have actually been completed, and the pharma industry top-line press release has been for both of these. One is dulaglutide weekly, and the other one is daily oral, an oral protein, and both of them, the press release said that they were effective and that they were cardioprotective. So we now have 7 GLP-1 receptor agonists that have gone through large randomized outcomes trials, and 5 out of those 7 trials have reported a clearly positive outcome on the primary outcome. 2 of them were not positive, but they were consistent with the others when you meta-analyze them. So these drugs are being used a lot, and one of the interesting side effects of this is weight loss. What about 3 to 5% weight loss? What about the SGLT2 inhibitors? These drugs have been around also about 5 years, and they were meta-analyzed. There's been 3 trials that have been recently meta-analyzed, and I'm going to go through them in the next few minutes. One of the trial had all patients with established cardiovascular disease. One had about 50% with established cardiovascular disease, and one had about 60% with established cardiovascular disease. And if you look at the effect of these drugs versus placebo, on, and these drugs work by making you pee sugar out into the urine. Interesting. They make you pee out glucose levels, and they cause a little bit of weight loss because you're peeing about 300 calories a day out when you pee out the sugar. They actually don't cause hypoglycemia. And so if you look at the effect on cardiovascular events, MI, stroke, CV, death, marginal. If you meta-analyze them, it's about a 0.89, about a 10-11% reduction. So that's not where their big strength is. Their big strength, and if you look at the individual components, it's sort of in that ballpark, about 10%. But if you look at, I'm going to skip that for time. If you look at CV death or heart failure hospitalization, this is really where the drama happens. You see a very clear 23% reduction in that composite outcome. And all three drugs examples of the class are very consistent in this regard. And you're going to hear more about these later. Heart failure hospitalization alone, 31% reduction in heart failure hospitalization when you meta-analyze them. Mortality, all-cause mortality, 15% reduction in all-cause mortality. Renal dysfunction. These drugs work in the kidney to make you pee sugar, and guess what they do? They also protect the kidney, interestingly enough. I'm not going to talk about mechanism. 45% reduction in renal decline, including renal function decline, not just albuminuria. And the interesting thing is the lower the GFR, the less effective on renal function, but the more effective they are in heart failure hospitalization and even on a MACE outcome. So I think you might hear a little bit more about that later. Amputations has been raised as a side effect. There's been 3 of these drug classes drugs have been tested in the class. Only one, canagliflozin, has reported an amputation signal. And you can see in this meta-analysis that there's a clear difference between them. There's a lot of heterogeneity in this particular meta-analysis. And so it's important to know that, and I tell all my patients about that, and I offer them the drugs. I say, look, there are the options, and we don't know whether there's a real effect or a fluke effect, but it's there. Fractures, again, only the canagliflozin has ever reported a fracture signal. Ketoacidosis, they all increase ketoacidosis. But we're talking about, look at the event rate, we're talking about essentially 1 per 1,000. So it's about 0.1%. It's 0.9 per 1,000 person years. So it's in the order of 1 per 1,000, 1 per 100, 1 per 1,000, pardon me. 1%, 0.9% per year. Nope, 0.09% per year. So it's about 1%, 0.1 per 1,000 per year. That's right. So it is a possibility, but the risk is low of ketoacidosis. So here's my final slide. Diabetes increases many serious health consequences. And I think I showed you it increases mortality, and I didn't show you it increases the risk of eye disease and kidney disease and cancer. Most cancers are more common in people with diabetes, as well as heart disease, cirrhosis, etc., and mortality. If I was Donald Trump and I was trying to tweet out one word about diabetes, I would say, diabetes, bad, very bad. Or sad, very sad. Glucose lowering clearly reduces eye and kidney disease, controversial effects and other consequences in type 2 diabetes. Glucose lowering drugs have important non-glycemic effects. So glargine, degludec, nateglinide, sitagliptin, alogliptin, saxagliptin, linagliptin, lixisenatide, and acarbose have all been proven safe and neutral on cardiovascular disease. Empagliflozin, canagliflozin, dapagliflozin, liraglutide, semaglutide, albiglutide, and dulaglutide reduce cardiovascular and renal disease. Exenatide may reduce death. And pioglitazone reduces cardiovascular disease in people without diabetes at risk for stroke. So if I had given this presentation 20 years ago to a group like this, it would not be uncommon for somebody to say, oh, at that time we had none of these trials. And we would have been talking about cardiovascular disease, and somebody would say, we know how to prevent heart disease in people with diabetes. All you got to do is this, this, and this. But the real truth is, we know exactly how to reduce outcomes, and we know exactly how to treat our patients when we have no good data. But now, 20 years later, or 15 years later, after 15 years of good clinical outcomes trials, we do know We know how to reduce serious health outcomes in people with diabetes, and we're going to continue to learn a lot more. It's been a great ride for all of us, and diabetes is now the second most evidence-based specialty in the world after cardiology when it comes to therapeutics and cardioprotection. Thank you very much for your attention. Any questions first?
Thank you very much. Outstanding. My pleasure to introduce our second speaker. Dr. Kim Connelly is a cardiologist and clinician scientist who is both nationally recognized as an expert in human and rodent echocardiography, cardiovascular MRI, and I'm sorry. I've got the yes, it's David next. Okay. I apologize. I'd like to introduce Dr. David Fitchett. Dr. Fitchett is graduated from Cambridge University in the UK. He was director of the CCU and medical director of the cardiac transplant program at the Royal Victoria Hospital, Montreal, and director of the cardiac ICU at St. Michael's Hospital in Toronto. He was the chair of the macrovascular section of the 2013 Canadian Diabetes Guidelines. He is on the steering and data safety committee for several international clinical trials on diabetes and cardiovascular disease. And currently, he is an associate professor of medicine at the University of Toronto and staff cardiologist at St. Michael's Hospital. Dr. Fitchett.
Thank you very much indeed for that introduction. I'm very honored to be able to discuss with you something which is very close to my heart, diabetes and heart failure. Over the last perhaps 10 years, we've gradually realized that heart failure plays an extremely important role in the outcome of patients with diabetes. But before I get going, these are my disclosures. This is how we are going to mitigate potential bias. You've seen this all before. So heart failure in patients with diabetes is frequent, forgotten, and often fatal, but I'd like to add something. It's often unrecognized as well. Diabetes plays a very central role in the development of heart failure. Diabetes has an effect on the myocardium, and you heard from Hertzel Gerstein that there is a direct effect causing a cardiomyopathy. It causes diabetic renal disease, which is a sodium-retaining state, enhancing the development of heart failure. And, of course, it causes premature coronary heart disease. So diabetes is very pivotal in the development of premature heart failure. Diabetes is prevalent in patients with diabetes on the blue line compared to non-diabetic individuals throughout the age. At a younger age, the relative increase in the incidence of heart failure is enormous because young people don't get heart failure if they don't have diabetes. As we get older, the incidence of diabetes in the non-diabetic population increases, but you can see even in the older population, diabetes causes heart failure much more frequently. If you have heart failure and you have diabetes, your outcome is awful. You can see here the 5-year survival in patients with diabetes with and without heart failure. At 1 year, 50% survival. This is terrible. You've seen this slide. The effect of diabetes on heart failure is as important in heart failure with a reduced ejection fraction and with a preserved ejection fraction. It doesn't matter where your ejection fraction is, your heart failure outcome is that much worse with diabetes. Heart failure has a greater impact on cardiovascular mortality than in patients who have had a myocardial infarction and stroke. And this is data from the placebo group of the EMPA-REG outcome trial. So the incidence of heart failure was almost twice that of non-fatal myocardial infarction. And you can see a patient who presents with heart failure has a higher mortality over 3 years than somebody who has a non-fatal myocardial infarction. And because of the increased incidence and the high mortality, the number of patients that died in the EMPA-REG outcome trial, which was not a heart failure trial at all, only 10% of the patients had investigator-reported heart failure at the time of initiation of the trial, but you can see more than twice the number of patients died with in association with heart failure than of a non-fatal myocardial infarction. Heart failure is often the first manifestation of type 2 diabetes-related cardiovascular disease, more than myocardial infarction or stroke. Interestingly, in this study, the most common cardiovascular presentation was peripheral vascular disease. Left ventricular dysfunction in diabetes is common. Mainly, the most common abnormality is diastolic dysfunction, but combined diastolic dysfunction and systolic dysfunction are present in this study in 68% of patients. Heart failure is frequently unrecognized, and this was a study done in Holland in which patients with type 2 diabetes and no history of heart failure were examined by an expert panel. They had an echocardiogram and they had to have evidence of either diastolic or systolic dysfunction. And what they showed was that in this group of patients, I think they were over 65 years old, 27% of these patients had unrecognized heart failure. The majority of them had heart failure with a preserved ejection fraction. The prevalence of undiagnosed heart failure was higher with the older patients, in women, in patients who were obese, patients complaining of dyspnea, fatigue, and in patients with hypertension. So over the past 20 or 30 years, there has been some improvement in outcomes, cardiovascular outcomes of patients with diabetes. Here you can see in the red line there has actually been some improvement in heart failure, although heart failure still remains the largest cardiovascular problem, much more than for recurrent or cardiovascular or coronary heart disease. So how are you going to reduce this risk? How are we going to manage patients with heart failure? Well, clearly prevention is very important, and I can't emphasize enough how risk factor management is important in preventing all categories of heart disease, including heart failure. And that includes lifestyle modifications, stopping smoking, good blood pressure control, very good lipid control, use of ACE inhibitors and ARBs, even in patients who don't have hypertension. These remain extremely important. A recent analysis of the STENO2 trial shows that if you control these risk factors well, patients will live up to 8 years longer than patients who have poor risk factor management. So symptomatic control of their symptoms is important. And then there are a number of ways which we can improve survival and prevent recurrent heart failure. But most importantly, management of diabetes, today there are agents which can reduce the risk of heart failure and improve survival. So this is my only slide of the general management of heart failure. And the blocks at the bottom, the beta blocker, the RAS inhibitor, and the mineralocorticoid, aldosterone antagonist, are the building blocks of management of heart failure. All the other things on top are additional fine-tuning measures, which are largely only used in specialized heart failure clinics. In patients who have significant heart failure and remain symptomatic, you may consider the use of an ARNI, such as Entresto, to improve outcomes. There are no specific trials in patients with diabetes, though the subgroups in all the trials of these agents have shown that all treatments are equally effective in patients with and without diabetes. Now, that was for patients with a reduced ejection fraction. Unfortunately, there is no clinical trial showing benefit in patients with a preserved ejection fraction. There are trends to benefits. For example, the Top Hat study with a mineralocorticoid suggestive that there may be a benefit, but that's not proven. Basically, the management of heart failure with preserved ejection fraction is symptomatic with diuretics, control of diabetes, hypertension, managing coronary heart disease and obesity. And we'd have no drugs which will improve survival, for example. So the risk of heart failure does relate to the severity of the diabetes and the A1C control. And here you've got the relationship between A1C, this is in the solid line, and the proportion of the patients, or the incidence of heart failure in the population. And you can see as the A1C rises, there is an increased incidence of heart failure. Unfortunately, as Herzl has shown you with cardiovascular disease, coronary heart disease, and stroke, control of diabetes, reducing A1C down to lower levels, does not have any impact on heart failure admission or heart failure mortality. So what about the impact of the individual agents on heart failure? And this is a summary. Hertzel has shown you that insulin is neutral. The only thing I would like to add to Hertzel's comments is that the ORIGIN trial was done in a group of patients who either had pre-diabetes or early diabetes, but none of them had established cardiovascular disease. There is no study with insulin so far in patients that have significant cardiovascular disease, including heart failure. However, I think the evidence is pretty good that insulin is neutral. Metformin, there are some meta-analyses, or no, at least observational data, which suggest it may be beneficial, but there's no clinical trial data. And as Herzl pointed out, there is no clinical trial data showing that sulfonylureas or glinides are benefit or harmful, although there are observational studies which suggest there may be harm. For TZDs, there is no question that both rosiglitazone and pioglitazone increase the incidence of heart failure, largely due to sodium retention. For DPP4 inhibitors, there is no signal of heart failure except for with saxagliptin, but it's very infrequent. You have to treat 140 patients with saxagliptin to see one case of heart failure. The GLP agonists are neutral, but then we come across the SGLT2 inhibitors. These are the first diabetes agent to reduce heart failure, and I want to spend the majority of the rest of my time talking about SGLT2 inhibitors and heart failure. So I was very fortunate to be on the steering committee of the EMPA-REG outcome trial. I was the only cardiologist on the trial, so I got to write all the interesting papers on heart failure. This was the first heart failure paper we published. So the EMPA-REG outcome trial, including patients with type 2 diabetes with an A1C between 7 and 10 who had established cardiovascular disease. A quarter of the patients had an EGFR between, less than 60 but above 30. And about 10% of the patients had an investigator-reported history of heart failure. We know no more detail about these patients. We don't know whether they had preserved or reduced ejection fractions. Hospitalization for heart failure was reduced by 35%. You can see the benefit from the empagliflozin appears early and is sustained throughout treatment. Similarly, the combination of hospitalization for heart failure and cardiovascular mortality was reduced by 34%, and the benefit again appears early, and the curves continue to diverge throughout treatment, suggesting an ongoing treatment benefit. We realized that hospitalization for heart failure was likely the tip of the heart failure iceberg. There were many other patients who presented to their physician with heart failure who didn't need hospitalization. This was not an adjudicated outcome, and we likely missed this heart failure. So we went back and we looked at the adverse event forms, and we found a considerable number of patients who presented to their physician with heart failure, and the investigator reported these on the serious adverse event form. These patients had a very similar outcome as patients who had adjudicated heart failure. Their mortalities were very similar. And in addition, we used a surrogate for heart failure. That was the introduction of loop diuretics. And you can see that empagliflozin had a very similar benefit on whether the patient was admitted to hospital with heart failure, reported to their physician with heart failure, or had loop diuretics started. We looked at patients, the 10% of patients who had heart failure, a history of heart failure when they were initiated into the trial, and that's the group on the right-hand side. You can see their event rates are about fourfold greater than patients who didn't have heart failure at baseline. And the benefit of empagliflozin is statistically the same in the patients with and without heart failure. We looked at the impact of empagliflozin on heart failure rehospitalization. So some patients on empagliflozin were hospitalized with heart failure. But what empagliflozin did in these patients was prevent rehospitalization. So you can see on the left-hand side, the 45, 60-day rehospitalization was significantly reduced. Interestingly, the 30-day rehospitalization wasn't reduced. And this is likely that the clock starts when the patient was admitted to hospital. We don't have any information of when the patient was discharged from hospital. If the patient was in hospital 2 weeks, a 2-week period to the 30 days may be too short to see a benefit. Anyway, it's clear that the 45-day onwards rehospitalization is reduced. So I hope this is clear to you. It's rather light. So in the EMPEREG outcome trial, patients who had some history of heart failure, be it heart failure at hospitalization or incident heart failure, that's presenting with heart failure at the hospital, or heart failure recorded by their physician, we call those patients who had a heart failure burden, and they're on the second line. And then the bottom line is patients who had no heart failure burden. The benefit of empagliflozin in reducing cardiovascular mortality was the same in patients with a heart failure burden and no heart failure burden. However, the incidence of cardiovascular events, if we look at the first column, placebo, is 15.3% mortality in the patients who had a heart failure burden, compared to 4.1% in the patients who had no heart failure burden. Consequently, the relative risk reduction being the same, the absolute risk reduction was substantial in the patients with heart failure burden. You can see that they had a 4.9% absolute mortality reduction, whereas the heart failure, the patients who didn't have heart failure, they only had a 1.4%. Interestingly, the patients with a heart failure burden accounted for almost 38% of the total mortality seen in the EMPEREG outcome trial, yet they were only 15% of the population. If you do a back-of-the-envelope calculation, 44% reduction of the cardiovascular deaths by empagliflozin occurred in these heart failure burden patients, who again were only 15% of the population. I think this shows how important heart failure and the impact of SGLT2 inhibitors on heart failure is in improving cardiovascular outcomes. Now, as Herzl has shown you, there have subsequently been 2 further SGLT2 inhibitor trials, one the CANVAS trial and the other the DECLARE trial. All 3 of them showed a very similar reduction in heart failure hospitalization. You can see that on the right-hand side. The MACE reduction was identical in the EMPEREG outcome and the CANVAS trial. The DECLARE study had 2 co-primary endpoints, and the co-primary endpoint, which was positive, was the reduction of cardiovascular mortality in heart failure. And if you go to, that's the penultimate column, if you go down that, all of those trials had a significant reduction of that combined endpoint. Only the EMPEREG outcome trial reduced cardiovascular this is all-cause mortality, by 32%, and the number to treat to prevent 1 death over 3 years was 40. So this is the results of the meta-analysis, which Hertzel has shown the major results. This is an analysis looking at whether patients with established cardiovascular disease, the outcomes, and in patients who just had risk factors. It's asking the question whether SGLT2 inhibitors are only beneficial in patients who have established disease. Should we be using SGLT2 inhibitors in patients who don't have established cardiovascular disease? And so this meta-analysis looked at this. So on the left-hand side, if we concentrate on the patients with established atherosclerotic cardiovascular disease, cardiovascular death and non-fatal myocardial infarction was significantly reduced, stroke was not affected, heart failure hospitalization, and the combined endpoint of cardiovascular death and heart failure hospitalization were significantly reduced. So an important impact on all aspects of cardiovascular events. In contrast, when we look at the patients with risk factors only, in patients who just have risk factors, these trials did not show any benefit for cardiovascular death or non-fatal myocardial infarction. But in contrast, heart failure hospitalization and the combined endpoint were reduced by similar amounts to the patients who had established cardiovascular disease. So a rather different outcome in patients with risk factors. The Emprise study was an observational study which was recently published, and it's only so far looked at the impact of empagliflozin on the reduction of heart failure. This was a study in which there were about 100,000 patients compared empagliflozin with new treatment with empagliflozin with new treatment with a DPP4 inhibitor being a neutral comparator. And you can see here that empagliflozin in this observational study reduced cardiovascular endpoint, reduced heart failure hospitalization by 44%. Only 25% of these patients had established cardiovascular disease. 75% of the patients only had risk factors. In this slide, we've broken down the heart failure hospitalization into groups without cardiovascular disease and with cardiovascular disease. And on the right hand of the slide, you can see the forest plot. And the point estimates for the reduction of heart failure hospitalization are statistically identical in patients with and without cardiovascular disease, suggesting that empagliflozin in this real-world study reduces cardiovascular hospitalization, heart failure hospitalization in patients with and without cardiovascular disease. So Subodh Verma, a colleague of mine at St. Michael's Hospital, wrote the editorial for the meta-analysis of the SGLT2 inhibitors, which was recently published. And essentially, he looked at the population of patients with diabetes as patients with and without established cardiovascular disease. And the triangle represents the population of patients with diabetes. About 80% of patients with diabetes have only risk factors and don't have established cardiovascular disease, and 20% have diabetes with established cardiovascular disease. So looking at the patients with diabetes and established cardiovascular disease and looking at the arrows on the left-hand side, we would expect an SGLT2 inhibitor to reduce major cardiovascular events, to reduce hospitalization for heart failure, and to provide renal protection. In contrast, the patients who have diabetes and multiple risk factors, we might expect very little effect on major cardiovascular events, but we would expect reduced hospitalization for heart failure and improved renal protection. The European Society of Cardiology heart failure recommendations came out with this position statement in February of this year, before the DECLARE study with dapagliflozin was published. And they said a significant breakthrough in contemporary cardiology was the finding that some type 2 diabetes drugs are associated with a lower risk of heart failure hospitalization in patients with cardiovascular disease or at a high risk of cardiovascular disease. And that 2 large randomized controlled trials, and I'm going to change it to 3 now because we have the results from the dapagliflozin DECLARE study. The 3 large trials assess cardiovascular safety with empagliflozin, dapagliflozin, and canagliflozin have shown a significant reduction in heart failure hospitalization with both drugs. The ADA, European Society of Cardiology recommendations recommend that when you have a patient on metformin who has not achieved their glycemic targets, the first question you should ask is, does this patient have established cardiovascular disease or chronic kidney disease? And if the patient has a condition which heart failure or chronic kidney disease predominates, or the patient has disease and you're very concerned about heart failure, then you should use an SGLT2 inhibitor. On the other hand, they say if atherosclerotic cardiovascular disease predominates, then you could use either an SGLT2 inhibitor or a GLP-1 agonist. In contrast, if the patient has no established cardiovascular disease, you can use any of the diabetes or the glucose-lowering drugs that you wish. However, I would suggest that in a patient with multiple risk factors, you might consider using an SGLT2 inhibitor to reduce the risk of heart failure. So how do we assess the risk for heart failure? Well, there are ways, and this was an application of a heart failure score, which I used in an analysis of the EMPEREG outcome study. The ABC heart failure score was published by Javid Butler about 10 years ago, and he has 9 factors which allow you to assess the risk, and they include age, the presence of coronary heart disease, blood pressure, heart rate, ECG left ventricular hypertrophy, smoking, the albumin level, fasting glucose, and creatinine. And you can see on the right-hand side, for the placebo group, there's about a 5-fold spectrum of risk according to the, so this is heart failure, cardiovascular mortality. There's about a 5-fold risk of this outcome according to the ABC heart failure risk. So if the heart failure, this is a 5-year risk. If the 5-year risk of heart failure is less than 10%, your risk of developing heart failure or dying is about 18%, whereas if your heart failure risk is greater than 20%, the risk is 70 per 1,000. So this is one way we might apply this score. This hasn't been recommended yet. This is my suggestion, but we can discuss this. But I think we need to better classify patients with diabetes. Not all patients are at high risk of developing heart failure, and this is one way of classifying them. We will know more about the use of SGLT2 inhibitors in heart failure through a number of clinical trials. The ones with empagliflozin, the EMPEROR trials, are looking at empagliflozin in patients with both reduced and preserved ejection fractions. The primary outcome is going to be heart failure, hospitalization, and cardiovascular mortality. And most interestingly, this is going to be done in patients with and without diabetes. So we'll have some data as to whether SGLT2 inhibitors are beneficial in patients who don't have diabetes. So my take-home messages are that SGLT2 inhibitors in patients with established cardiovascular disease all reduce the combined endpoint of heart failure, cardiovascular mortality, heart failure hospitalization, and stabilize chronic kidney disease. At the moment, the only drug which reduces cardiovascular mortality independently is empagliflozin. So SGLT2 inhibitors in patients with type 2 diabetes with cardiovascular risk factors only reduce heart failure and stabilize kidney disease. And I think we should be considering the use of SGLT2 inhibitors more widely in patients with both established cardiovascular disease and with risk factors only to prevent heart failure, stabilize renal function, and in the patients with established cardiovascular disease to reduce cardiovascular mortality. Thank you very much.
Thank you, Dr. Fitchett. I'm learning so much this morning, I can't believe it. There will be many questions, I think, because I have 10 in my head already. I'd like to now introduce Dr. Kim Connelly. Dr. Connelly is a cardiologist and clinician scientist who is both nationally recognized as an expert in human and rodent echocardiography, cardiovascular MRI, and the impact of diabetes upon cardiac function. His work has been recognized by winning the Young Investigator of the Year Award in 2012 by the Canadian Cardiovascular Society, an Early Researcher Award in 2014, and a CHR New Investigator Award in 2014. In 2015, he was awarded the SC Verma Young Investigator Award and Heart and Stroke Foundation of Canada Richard Luer Centre for Excellence in Toronto. Dr. Connelly runs a basic research laboratory at the Keenan Research Center at St. Michael's Hospital, where he focuses upon basic mechanisms of disease with a focus upon translating discoveries into therapies in humans. He is the director of the Kremble Stem Cell Facility at St. Michael's Hospital and uses stem cell-based therapies to improve cardiac and renal dysfunction as a result of diabetes. Dr. Connelly.
Okay, thank you, and good morning, everyone. I promise I'm not going to talk about any rodent or animal studies. I think that will bore everyone to tears, and it's been a tour de force. So what I thought we might do this morning is we've heard a lot of information, outstanding talks by Hertzel, Gerstein, and David Fitchett, but after David actually stepped off as chair of the macrovascular complication sections for Diabetes Canada, I took over. So what I thought we would do is actually look at guideline-based evidence to how we can translate all this clinical trial data into practice. And I'm going to focus not just on glycemic control, but also on how we can look at blood pressure control, lipid control, so that we can really focus in reducing overall cardiovascular outcomes in our patients with diabetes, because we clearly know glucose is important, but it's only one of the factors that we need to treat to have a major impact on outcomes. So you'll see here from my disclosure slide, I'm conflicted, and as my wife tells me, confused as well. Mitigating potential bias, you've heard this before. As I said, everything that I'm really going to present today is in the 2018 Diabetes Canada update, so I should not be going off-label at all. Anyone's welcome to any of the slides we've got, and I actually forgot to put the URL in for Diabetes Canada, but if you put it in Diabetes Canada, you'll see access to all the information, material, and everything that we will talk about today. So let's keep moving forward. So really what I wanted to focus on predominantly today was type 2 diabetes. I'm not really going to say much about type 1 at all, and really focus predominantly on vascular complications. You heard from David Fitchett, who's really one of the world leaders in this heart failure SGLT2 story, but I really want to focus a little bit more on the vascular complications, but of course not ignoring the very important heart and renal failure signal that's emerged from the recent clinical trials, and then really to talk about where we are with the ABCDESs in terms of that sort of global risk factor reduction for our patients with type 2 diabetes. So, just again to give some more numbers, I like this slide because I think it also helps to put things in a little bit of perspective. You heard very elegantly from both Herzl and David about how important it is when we look at clinical trials. About a quarter, or actually about a third to 40% of all the major randomized clinical trials that are done always have many patients with diabetes in it. And that's important because, as you can see, it drives about a third of all heart attacks and strokes, 2/5 of all heart failure admissions, 2/3 of all non-traumatic amputations. So to put it into context, the most common presentation actually for diabetes complication is in fact peripheral arterial disease, 2/3, and then followed by heart failure, then actually myocardial infarction and stroke. And you'll notice here that I've put in about half of all patients who start dialysis or end-stage renal disease have diabetes. Why is this important? Well, what do you die of if you have end-stage renal disease and dialysis? 80% of those deaths are vascular complications. The rest are probably infection and malignancy. But you can see then that ultimately the pump is the sort of weak point in the entire system. So everything will ultimately converge on that. How big a problem is at the moment? 1 in 10 deaths in Canada is as a direct result of diabetes. 1 in 10. we have about 3 million people out of about 35 million population with a formal diagnosis of type 2 diabetes. But if you include the pre-diabetes and diabetes, we're 10 million people, so roughly a quarter of the population. And unfortunately, as we've moved forward, the numbers are not getting less. They are actually increasing. And just as an aside, and we don't actually know the reason why, if you look at the recent mortality data in the US, we've seen that the US, which was actually improving mortality, has actually dropped again. And I suspect, we don't exactly know, but we think it's this diabetes, obesity epidemic, and the way we've changed our lifestyle is really a main driver of this. So this is an incredibly important problem, and it's not reducing, despite the fact that we've been studying this for many, many years. So when we think about how do we then actually implement changes to reduce overall risk for our patients once they've made a diagnosis of diabetes, an HbA1c greater than 6.5% or a fasting plasma glucose greater than 7. And you can see here that there are a number of recommendations. Again, this is taken directly from the clinical practice guidelines. And here I think it makes it a little bit easier for you to see there. So what do we focus on? And really, I think when we treat our patients with diabetes, we need to go holistic. Glycemic control is important, but it's only one of a number of factors there. And you'll see here, we can focus on, if I can get the pointer up, HbA1c, blood pressure, lipid lowering, drugs to protect the heart, and I'll go through those in a little bit more detail. And of course, this is in combination with exercise and healthy eating, screening for complications, very importantly, smoking cessation. Just to put it in context, remember I mentioned before peripheral arterial disease, a diabetic who smokes has a 500-fold increased risk of losing their limb. It's not 10, it's not 20, it's absolutely out of control, the increased risk. So it's extremely important to remember smoking cessation. And then, of course, we need to look at more holistic thing to try and make certain that all these excellent recommendations that we make are actually followed on. Because as we all know, a medication can only work if you actually take it. So, where do we start at the moment in regards to targets and treating our patients with type 2 diabetes? So this is taken directly from the clinical practice guidelines, and you'll see, very importantly in this, that alongside all the pharmacological therapies, you'll see healthy behavioural interventions. So not forgetting all those other important things regarding diet and exercise. So once the diagnosis of type 2 diabetes is made, in everybody we start healthy behaviour interventions, nutrition therapy, weight management, physical activity, and of course first-line therapy for our patients with type 2 diabetes, metformin, unless they have significant renal impairment. And then we can basically move down depending on what the A1C target is and whether or not they have symptomatic hypoglycemia and or metabolic decompensation. So this will just sort of step through in yellow as we move through there. So you can see here, depending on the A1C target, you can then determine what the second line of therapy should be. If they are symptomatic or metabolic decompensation, then of course you'll initiate insulin, usually in the inpatient setting, to try and control that. Could potentially be done in the outpatient setting if you're comfortable with that, but often that does occur in the inpatient setting. And then I think the next step moving forward is, can we actually modify hard cardiovascular outcomes? And so this is how it's been integrated into the guideline statement. After metformin, if they're not symptomatically decompensated, we then ask the question, is there clinical cardiovascular disease? And if the answer is yes, then we move forward with one of the therapies that has been proven to reduce hard cardiovascular endpoints. Now you'll see here that there is empagliflozin, liraglutide and canagliflozin, although you'll notice that both David and Hertzel presented data with a number of other newer agents. This was published in April of this year. We're moving forward to update it, but this is, if you get on the website, this is the data as we are at the moment. And then there's different levels of evidence. And importantly, when Diabetes Canada goes through to grade this, it's a very complicated process looking at the benefit, the potential risks of the therapies, and then what was the evidence performed in randomized clinical trials, and that's how we then deride the grades and level of evidence. Once you've then made your decision, do they have clinical cardiovascular disease? And then most of us, I think, would agree that it is appropriate to start on either an SGLT2 inhibitor or a GLP-1 receptor agonist. Then, of course, we repeat and look at their glycemic control and then move forward to say, well, are you at target or not? And if you're not at target, we can then consider subsequent therapies. If you do not have established cardiovascular disease, then it's not unreasonable to use the sort of what I would call the more standard therapies, sulfonylureas, DPP4 inhibitors, etc., as you see fit. So it's really that, if you like, that fork in the road is once we've identified the patients have established cardiovascular disease. So what are the targets that we should be aiming for in terms of A1C? Well, in most adults with type 1 or type 2 diabetes, an HbA1c is less than 7 is appropriate. If you can achieve that without a risk of hypoglycemia, then you may want much tighter glycemic control, aiming for 6.5. And as Professor Gerstein said, this is because, although I'm focusing on vascular complications, if you ask most patients what are they worried about, they're actually worried about going blind, and they're actually worried about end-stage renal disease and going on dialysis. So it's extremely important that if you can achieve that low target, you will reduce the microvascular complications, but it needs to be done without the expense of hypoglycemia, because as you're all aware, patients hate hypos. They really do not like them, they scare them, and it changes subsequent management. Now, if you have a group here that is what we've described as functionally dependent. So those that, if you like, have less life expectancy, are frail, dementia, we want to control their glucose levels so they're not symptomatic with it, but you may then ease off on the glycemic targets there, and you'll see the HbA1c should be between somewhere around 7.1 to 8.5, because that then means, you know, I think you're making certain that they're not symptomatic, but of course the goals then is really comfort. It's not necessarily reducing hard cardiovascular endpoints, which we would focus on for really the healthier group, if you like, for want of a better term, where we'll aim for less than 7. Now, importantly, across the board, we want to avoid symptomatic hypoglycemia, and of course, we want to avoid hypoglycemic episodes. And of course, at the end of life, I think then it's appropriate to stop really all that therapy and not measure an A1C, because that's not the goal of care. And I think as we move forward with an ageing population, this will become more and more important as we start to broach appropriate questions regarding end of life and making certain that patients tell us what their preferences are before we actually end up in what happens. Unfortunately, most of the time currently, you end up as an inpatient in hospital in a bad situation, and then we're trying to backpedal and figure out what the goals of care are. I think this really needs to be moved back 5 or 10 years so patients can actually tell us what they want so that their wishes are respected, and it's not just a sort of a last-minute decision. Now, as we mentioned before, how do you actually achieve glycemic control? Well, this is really, and again, Hertzel eloquently went over this. This is a slide really just to get back to the point that he made, that it was complicated before we had the newer therapies such as SGLT2 inhibitors or GLP-1 receptor agonists. And you'll see that when we look at clinical trials such as the ADVANCE, VADT or ACCORD clinical trials, which were done really using insulin, sulfonylureas, thiazolidine, diones, DPP4 inhibitors, that when we looked at did the strategy of glucose lowering alone reduce macrovascular events, cardiovascular mortality, or myocardial infarction, you'll see, as he mentioned, it's a very complicated story. It wasn't clear. It was a little all over the map. But again, still important to control diabetes because that reduces microvascular events, but the macrovascular story was not at all clear. Moving forward, however, you've seen then a lot of data moving forward, and what I've tried to do here is break it down into those data that we have when we're considering the anti-hypoglycemic agents into those where superiority is being demonstrated in a primary endpoint randomized clinical trial. And in no particular order, there's the GLP-1 receptor agonists and SGLT2 inhibitors, and tried to put it in context of, well, what's their impact on A1C lowering, the risk of hypoglycemia, do they impact heart failure, and do they have an effect on blood pressure? And you'll see here that both the SGLT2s and GLP-1s are very potent at A1C lowering. They do not cause hypoglycemia alone. It's really only the SGLT2s that have, for want of a better term, class have had a major impact on heart failure, but both agents do impact blood pressure, although the magnitude with SGLT2 inhibitors is greater. If we looked at trials which have been done to look for cardiovascular safety, the DPP4 inhibitors are clearly neutral. The only issue there was that small increase of heart failure hospitalization with saxagliptin. The thiazolidine diones are overall neutral, but clearly increased heart failure. And insulin, as the trial's really done and championed by Hertzel himself, demonstrate a very impressive A1C lowering and neutral for heart failure and blood pressure. But of course, there is the risk of hypoglycemia. And as yet, we do have a number of agents that we don't really have any data on as yet, the most common being used are the sulfonylureas. So this is to try and break it down in, well, if you're thinking about which agents, which one should we go to next? So now I've tried to break it down a little bit in those where we've demonstrated superiority. And again, there's a number of trials, and I know this is a busy slide, but what I really wanted to focus on is you'll see that as you go from the SGLT2 inhibitors here, EMPA, Cana, DAPA, and then we compare those to the GLP-1s, Lira, Sema, albiglutide, that you'll see as we move from the primary endpoint to the secondary outcomes where we look at cardiovascular death, non-fatal MI, non-fatal stroke and heart failure hospitalisation, that you're seeing different signals emerge within these agents. And as David nicely went through, we can clearly see as a class that the SGLT2 inhibitors all seem to have this robust reduction in heart failure hospitalisation, which is not seen with the GLP-1 receptor agonist, whereas we see in the SUSTAIN 6 trial with semaglutide, there was a 39% reduction in non-fatal stroke. In the HARMONY trial, which was with albiglutide, which is not available in Canada currently, there was a 25% reduction in non-fatal MI. And this is important when we think about our vascular protection, because I think you can see that we're seeing differences emerge with the different agents. So if you're worried about the patient with heart failure, then obviously the SGLT2 inhibitors may be the go-to agent first line. If you're worried about the MI risk and stroke risk, then the GLP-1 receptor agonist may then be the choice to go for. And so some people have broken this down into sort of these agents, the GLP-1s are atheroprotective, whereas the SGLT2 inhibitors are heart failure protective. Well, I think it's going to emerge as we get more data. It's not quite as simple as that, but of course the problem we have at the moment is we have this huge amount of data sort of bombarding us. I think this is not an unreasonable way to break it down at this particular point in time, but as more data emerges and we have more meta-analyses, I think the signals will become clearer. But the good news is they all show superiority, which is a great day for our patients with diabetes, because now we don't just have 1, 2, 3, we have multiple agents with different classes. And of course, as we move forward, it's going to be very interesting to see that if we combine an SGLT2 inhibitor with a GLP-1, will we get even greater benefit? But we do not have that data as yet. So what's the Diabetes Canada recommendation based on all that? In adults with type 2 diabetes with clinical cardiovascular disease in whom glycemic targets are not achieved with existing anti-hypoglycemic medications, an anti-hypoglycemic agent with demonstrated CV outcome benefit should be added to reduce the risk of a major CV event. And when that was done, empagliflozin, liraglutide and canagliflozin were the agents that the major clinical trials have reported out in. I think semaglutide is clearly reasonable to be added to that list, but it hasn't been updated yet within the Diabetes Canada guidelines. But there is a group getting together to then take into account all the new clinical trials, so hopefully we'll see an update early 2019. So that's the glycemic step. Now, what about other risk factors that we can control? So blood pressure. So this is, and when we talk about blood pressure here, the Diabetes Canada guidelines have been harmonised with Hypertension Canada. So the two have got together so that we don't have different organisations giving different blood pressure targets. So these were done in conjunction and together, and this is to make a diagnosis of hypertension in patients with diabetes, the blood pressure target is greater than a systolic of 130 and a diastolic of 80, confirmed on a second occasion in either the office, home, or by appropriate ambulatory measurement. So greater than 130/80 is a diagnosis of hypertension, therefore we want to aim for a threshold less than that. So this is the recommendation from the clinical practice guidelines. Persons with diabetes should be treated to attain systolic less than 130/80. For persons with clinical cardiovascular disease or chronic kidney disease, including albuminuria, or with severe risk factors in addition to diabetes and hypertension, an ACE or an ARB is recommended as initial therapy. and if blood pressure targets are not achieved with standard dose monotherapy, additional antihypertensive therapy should be used. For persons in whom combination therapy with an ACE inhibitor is being considered, a dihydropyridine calcium channel blocker such as amlodipine is preferable to a thiazide-like diuretic with grade A level of evidence. So what drives the targets for this? Well, really the early studies was the hypertension study of the UK PDS, and you'll see here that they looked at less tight control, which was a blood pressure of 154/87 versus tight control 144/82. Now, we actually are aiming for much lower than that, but this was really historically the first data to suggest blood pressure control in our diabetic patients is important. We need to aim for lower targets. This is how you get there. This is just another schema to show what we talked about. If you've got nephropathy, CVD or CV risk factors, we use an ACE or ARB first. If you don't have that, then you can consider ACE or ARB or a thiazide diuretic or a dihydropyridine calcium channel blocker. And if you're not at target quickly, you can use a combination therapy there. So why do we prefer the combination of a dihydropyridine calcium channel blocker with an ACE inhibitor versus an ACE inhibitor with a diuretic? Well, this was the accomplished study, which used the ACE inhibitor benazepril plus hydrochlorothiazide versus benazepril plus amlodipine. And if we look in the diabetes subgroup with the MACE endpoint, there was a 21% risk reduction, suggesting that there is a synergistic effect with the calcium channel blockers and ACE inhibitors over benazepril and hydrochlorothiazide. So it's not wrong to use the ACE inhibitor plus a thiazide-like diuretic, but there is some data suggesting that the calcium channel blocker is preferable. So that really drives that particular endpoint. The other important thing, and this was a little bit of a change in the update in 2018 compared to 2013. In 2013, we basically said anyone greater than 55 years of age, you should consider an ACE inhibitor or an angiotensin receptor blocker. When we went back and looked at the data, and there was actually a number of letters that were written into the Canadian Journal of Diabetes saying, well, I'm not certain if you've been true to the data, and I'll explain what I mean by that. So this was actually an update, and you'll notice here that there's a little caveat. If you have clinical cardiovascular disease, then an ACE inhibitor or an ARB at doses that have demonstrated vascular protected should be used to reduce cardiovascular risk, and the doses are described here: perindopril 8 milligrams, ramipril 10 milligrams, telmisartan 80 milligrams. If your age is greater than 55, we've added in the caveat that you should consider an ACE or ARB with an additional CV risk factor or end organ damage such as albuminuria, retinopathy, or left ventricular hypertrophy, or you should consider the use of these drugs when there is microvascular complications present. So why was there this change from everyone over 55 to focusing in on those with additional CV risk factors? Actually, what I might do is I'll go forward and show you the reason and then show you the data why we recommend ACE or ARBs. This was a meta-analysis published in 2016 in the BMJ, and what they did is they looked at RAS blockers compared to all other agents, antihypertensive agents, to see whether or not there was one agent that was superior. And I know it's a complicated slide, but you can basically see at the bottom line here that it really lines up to unity. The relative risk here was no particular difference here. So it didn't say that unless you had one of those risk factors that there was any particular magical advantage of an ACE and an ARB over, say, using a calcium channel blocker. Once you have one of those risk factors, then there's no doubt there's a beneficial effect. And that beneficial effect was really seen here, which was the micro-HOPE sub-study that again was led by Professor Gerstein and the HOPE study investigators, where we can see here in the micro-HOPE analysis of the ACE inhibitors, you can see clear benefits in terms of overall primary MACE outcomes, mortality here, MI, stroke, and cardiovascular death. So that's the rationale for ACE inhibitors and ARBs once you've got one of those risk factors. But if you don't have one of those risk factors, you can pretty much pick any antihypertensive agent. Now, despite all that explanation, when we went back and looked at the number of people that this recommendation was likely to change, most patients with type 2 diabetes over the age of 55 indeed have one of these risk factors. So it probably doesn't make that big clinical benefit in the end, but I think we're trying to be true to the data, and that's what you need to do when we're doing clinical practice guidelines. So importantly then, moving forward, what about statin therapy? So it's been reported out before that if we go and look in a lot of the clinical trials that have been done in the diabetic field, that up to 70% of the reduction in macrovascular events is driven by statin therapies. So these are extremely important, they're profound, and that's why really the guidelines, when you look at them, are very broad. That in patients with type 2 diabetes, anyone with clinical cardiovascular disease, age greater than 40 years or less than 40 with diabetes duration greater than 15 years and age less than 30, or microvascular complications, or you warrant therapy based on the presence of any other risk factors according to the 2016 and to be updated 2019 Canadian Cardiovascular Society for Guidelines therapy. So you can see very, very broad indications for the use of statins because they are such profound drivers of reductions in major vascular events. And really specifically, we do have data in the primary prevention of patients with type 2 diabetes. This was the CARDS trial, published a number of years ago, looking at atorvastatin 10 milligrams, and you'll see here that whether it was acute coronary events, coronary revascularization, stroke, death from any cause, almost made it there, 0.059, but any acute cardiovascular disease event, you can see an overall overwhelming benefit. And this is in the primary prevention group. This is not those in secondary prevention. Clearly, secondary prevention, everyone should be on a statin, but it's based on this recommendation that really anyone over the age of 40 should be on a high-intensity statin to reduce vascular disease. Now, there's a few more caveats that come with this. We have some more up-to-date data. The first was with the Improve It trial, which was the addition of ezetimibe, and then I'll put in the data looking at the PCSK9 inhibitors. So you remember this was reported out a number of years ago, and Improve It trial was the addition of ezetimibe to simvastatin. And really the question was, we know getting cholesterol and LDL lower with the statin works, but what about other agents to reduce LDL? Do these have benefits over and above just statin-based therapy? And also to look at the safety. Here's the primary endpoint here. There was a 10% reduction in the hazard ratio of cardiovascular death, non-fatal MI, non-fatal stroke. You can see the absolute risk here, 22% in Simva alone versus ezetimibe versus plus simvastatin. But if we look at the diabetes subgroup here, you can see then that there was some heterogeneity there, suggesting that there was in the pre-specified subgroups that it was the diabetic patients that had even greater benefit. So if you're not at target with your LDL, there is clear data to suggest that LDL lowering further with ezetimibe has a benefit in our patients with type 2 diabetes. The second data that comes along is now with the use of agents known as PCSK9 inhibitors. The first trial that reported out that we actually have a specific diabetes sub-study that's been published in the literature, and that's why I put this one in with Repatha or evolocumab. There is Pro-UN or alirocumab, which was the Odyssey outcomes trial. We have not seen a specific diabetes paper being published with that yet, but just to remind us all, in the Fourier trial, it was 27,000 high-risk patients with established cardiovascular disease. So this is all secondary prevention. This is not primary prevention. You had to be on a high or moderate intensity statin. You can see what the LDL targets needed to be here, and if you didn't meet those, so if you're greater than 1.8 LDL, then you could be randomized to evolocumab or placebo, and then there was a number of years follow-up. And what we can see here, if we look at the primary endpoint, cardiovascular death, MI stroke, hospitalization for unstable angina or coronary revascularization, you can see this is the patients with diabetes at baseline. And there was over 13,000 patients, so this is a very, very large sub-study on its own. You'll see that the absolute event rates were greater than those without diabetes at baseline. The hazard ratio, if you were treated with Repatha here, was the delta here in that endpoint I mentioned there was 1.6% with the number needed to treat of 62, whereas if we focus in on the diabetic subgroup, the delta then was 2.7% with the number needed to treat of 37 there. So there is data for PCSK9 inhibitors. As you're aware, there's cost issues and so on. I think as we move forward, hopefully these will become more widely available. Now, finally, what about aspirin for primary prevention of cardiovascular disease? Certainly I know that many of my patients, despite me giving any recommendations either for or against, they come in, I ask them what medications they're on, they say I'm on a statin, they say I'm on an ACE inhibitor, they say I'm on metformin, and then they don't even mention to tell me that they're actually on aspirin. And then I say, well, actually, are you on aspirin? Yes, I am. Well, who prescribed it? I didn't prescribe it. Oh, aspirin's cures you, fixes you from everything. So I just decided I would take it. I usually then ask, well, how much do you take? 325, 650, I just take what's in the little bottle. So is there data that this should be the panacea for all vascular complications? Well, unfortunately, if you look at the net clinical benefit, it does not appear in the primary prevention group. Secondary prevention, absolutely no doubt, patients should be on an aspirin. But for primary prevention, is there data? This is a meta-analysis. It's published a number of years ago. Aspirin for primary prevention of cardiovascular events in patients with diabetes. If we look over here at the data, you'll see if we look at major cardiovascular events from these trials, really sits on the line of unity. Myocardial infarction, line of unity, stroke, line of unity, death from CV causes, all-cause mortality. Now, this is older data. There's 3 very large trials that have reported out this year. They haven't made it into the guidelines, so I haven't included them, but they also show the same thing, that yes, in some patients you may get a reduction in vascular events, but if we look at the bleeding risks, major bleeding, gastrointestinal bleeding, extracranial bleeding, that those are increased. So the overall net benefit is fairly neutral. So that's not to say in some patients where you really believe that the risk-benefit ratio may be in your favour to consider aspirin as a primary prevention. You could do that, but as a broad evidence-based guideline, should we put everyone on aspirin therapy? For primary prevention, the answer is no. Okay, so this is the recommendations from the guidelines in patients with established CV disease, no-dose, low-dose aspirin therapy should be used. 81 milligrams, just as a little anecdote, do you know why 81 milligrams was chosen? Well, 80 milligrams is the pediatric dose, and so Health Canada said you can't have the pediatric and the adult doses mixed up, so Bayer said we'll make it 81 milligrams, and they said no problem. The minimum dose you can get away with for benefit is 75 milligrams. So doses less than that, there does not appear to be any of the vascular protective effect. But aspirin should not be routinely used for primary prevention of cardiovascular disease in patients with diabetes. There is some more data coming out with some of the dual-only platelet therapies for those with established cardiovascular disease. This is one such trial looking at ticagrelor. This was the Pegasus trial. 21,000 patients who had had a previous MI 1 to 3 years before, and they were treated with low-dose aspirin. You can see here whether or not you're on 60 milligrams BID or 90 milligrams BID of ticagrelor. There was a benefit in favour of ticagrelor there. You can see the p-values here with an overall 15% reduction. But there was a specific diabetes sub-study there. Again, a large sub-study of the overall group, 6,800 patients. As anticipated, if you have diabetes, your overall event rate, CV death, MI, stroke are increased. However, there was still a beneficial effect in favour of ticagrelor in that group. So you may then consider longer-term dual antiplatelet therapy, but again, this is only in those for secondary prevention who've had a previous MI. So what are the key messages for people with diabetes? Well, there's no doubt we need to focus on glucose control. We have a number of new agents, and you can see now we've got to that important fork in the road with the clinical practice guidelines uptake, and when you may consider an SGLT2 inhibitor or GLP-1 as, if you like, second-line therapy before you move on to other agents. But it's important to make certain we look at blood pressure, cholesterol, drugs to protect the heart, exercise, healthy eating, and importantly, stopping smoking and managing stress. So with that, I'll stop and thank you very much for your attention.
We have about 20 minutes for questions. Any questions from the audience at the microphones? There's one here on the right.
I have a question for speaker number 3. If it's obvious that aspirin should be is recommended for secondary prevention if you've had a heart attack, for instance, and in primary prevention, if you're about to have a heart attack, it's not logical to me that you wouldn't be using it also for primary prevention.
Yeah, so I tried to nuance the discussion a little bit there to say there may be certain individuals whereby there may be a benefit in using aspirin for primary prevention. But the strategy of should everyone in society, if you like, who's got diabetes just automatically go on aspirin, it doesn't appear to work, because it's a competing risk thing. We have the potential benefit in terms of reduction in vascular events, peripheral arterial disease, stroke, coronary disease, versus the bleeding risk. And when you move from the individual patient to then very large populations, we know that the bleeding risk increases. And this is this concept, if you like, of net clinical benefit. What's the overall benefit risk? So there may be individuals with which you say, okay, I think overall the benefit is in favour that I'm going to take the small risk of bleeding, because it was predominantly GI bleeding that we're seeing, although there is some intracranial bleeding, it's predominantly GI bleeding, and I'm going to take that into account and say that it's reasonable to prescribe the aspirin. But this is very different from another group such as, if you like, such as the NOACs. Okay, let's think about what we do with the oral anticoagulant therapies. We know that there's a defined bleeding risk, but the overwhelming benefit in favour of patients with atrial fibrillation is so clear that you'll take that bleeding risk and go with it. Whereas when we're thinking about aspirin therapy, yeah, there is a benefit, but it's pretty small. So when you put that in context of the bleeding risk, which is also small but real, the net clinical benefit comes out neutral. So it's, as I said, overall, and the guidelines try to say that for the majority of patients, we wouldn't recommend it, but in certain individuals, it's not wrong to say you've looked at that net clinical benefit and believe it is in their favour to take aspirin.
Can I just add to that? I mean, there was also, after the meta-analysis that Kim showed, there was a large, very large randomized controlled trial focusing exactly on that question, the United Kingdom, called the ASCEND trial, which randomized people to 81 milligrams versus placebo, followed them for about 7 years, and the benefit, you're right, total, there was actually a reduction in events, but the absolute risk of serious bleeding was higher than the absolute risk of benefit. And that's why for primary prevention, there's recommendation against it. So totally right what Kim said.
A question on the left.
Another aspirin question, but as a family doctor, I have patients who are self-medicating with aspirin, and to have the conversation with them about whether to stop or not. That's the question, because if I say stop and then they have a heart attack a year later, it's kind of my fault.
Yeah,
of course it's your fault.
Yeah, I think it gets back to this point that when we think about all of the antiplatelet therapies, there is a defined bleeding risk. We certainly know there's people who are at greater risk, the frail, the elderly, concomitant non-steroidal anti-inflammatory use, renal impairment and so on. They're much more likely to get it. However, if they've been on it for a while, if you like, they've already done the stress test to themselves. So then I have that discussion and say, look, if you're going to go on it and stay on it, you've probably put yourself in a lower risk group because you haven't had the GI bleed, but it is important to realise that other things can increase your risk. So please understand that you need to be careful of non-steroidal anti-inflammatories, and then I try to go through that discussion that way. But again, unfortunately, we did ourselves a disservice as, I think, healthcare professionals, where we sort of all jumped on the bandwagon before we had the evidence and said aspirin's the great panacea, and now we're finding it's a good drug, but there are nuances, and I think, I'm sure David and Herzl can comment on this, but I think if we tried to get it through a regulatory agency today, it would never make it through.
A question on the right.
Sorry, question for Dr. Fitchett, please. Should we consider using SGLT2 drugs in non-diabetic patients with heart failure?
So I wish I could answer that for you. It's a very important question which is being looked at in the EMPEROR trials and in the DAPA heart failure study, where patients with heart failure were randomized to an SGLT2 inhibitor or placebo with and without diabetes. Until we have that data, I think that we should not be using SGLT2 inhibitors in patients with heart failure who don't have diabetes. We'll know that data perhaps in 2 to 3 years' time, but it's a very, very interesting question. There are good reasons why it may well work, independent of glucose lowering.
Question on the left.
Thank you.
Yeah, well, we're having fun with the aspirin theme, so just a couple of other comments or perspectives. So the one is it truly primary prevention if a lot of these patients with diabetes actually have had silent infarcts? So the majority of patients with diabetes, if you look, will have had silent lacunar infarcts, may have carotid artery disease. So is it primary or secondary in that context, and how much should we probe for end organ damage and say we're actually giving this for secondary prevention? And then I have the other point, and that is when you ask a patient, okay, well, here's a baby aspirin a day, what's the worst thing that can happen? Well, you might have some bleeding, which you can transfuse. A few weeks later, a month later, you'll be back to your usual self. What's the worst thing will happen if you don't take it? Well, you could have a stroke, which will disable you for life. So it's also pick your poison. A couple of.
Well, can I just comment?
Yeah, absolutely.
I mean, if you get an intracerebral bleed as your stroke, then well,
that's not the common thing. It's the major GI bleeding.
But actually, with the ASCEND trial, there were actually serious. A lot of them were intracranial bleeds too. So this is just a comment. I don't know what my colleagues think about this. I'm not a cardiologist, but I don't think it's useful to classify people in primary versus secondary prevention. It's just a short form. Really, the best way to think of people is risk. So if somebody has not had a heart attack and they've got a GFR of 30 and they have angina and they have, or they have a GFR of 30 and they're hypertensive and they have an LDL of 3, is that primary prevention or secondary? Their risk is a lot higher than somebody's had a small right vessel, coronary, a right inferior MI, 3 years ago or 5 years ago, and they're fine. So I don't think we should think about primary versus prevention, primary versus secondary prevention at all. We should be looking at our patients and estimating in a very clear, we don't have to sit there with funny calculators. We can just look at them. We know, we've been practicing medicine for 5, 10 years. You can pretty well figure out, this person's risk. Is this person high risk and low risk? And then you can use your judgment as whether to use a drug. But if you're using somebody who's never had any events, who's a 50-year-old executive, who's normotensive and everything else, they happen to have diabetes alone, even though they're 50, their risk of an event is low, and I wouldn't give them an aspirin. So I think it's really, it boils down to clinical judgment, and there are no formulas here. The evidence that we have is informing that judgment. So, but I don't think primary versus secondary, it's not really useful.
I totally agree.
What, you agree?
Yeah, I think the other point too is when we look at the totality of the clinical trial data, though, we don't see a big signal. It's not, with the sort of change, even if you looked at, let's say we ignored the bleeding risk and we just looked at the vascular events, there's a small event there, but if I put the numbers up, none of you would turn around and say, this is enough that I'm going to actually change my management strategy. It's not anywhere near the same magnitude we see with statins, blood pressure lowering, SGLT2 inhibitors, GLP-1 receptor agonists. So if we saw that vascular protection was so great, then I think we would say, okay, we're going to accept it. Yeah. But we're talking actually a very small signal, and then we see this overall net benefit. So that's why I think the one-size-fits-all strategy is not appropriate. But I completely agree, and as I said, I think there are individuals where you're going to say, no, I've got a very good rationale why I do believe you're protected, may be protected, and therefore I'm going to prescribe the drug. And the question is, how hard do you push? Well, I think that's a clinical judgment. We tried to write in the guidelines to get an ECG once a year. You may consider stress testing, ankle brachial indices, and so on. But I think a lot of this can be done simply with a good clinical judgment, as Hertzel said, at the end of the bed, and with a few very simple blood panels, which we would recommend in all the patients, and maybe an ECG, and then you can risk stratify further depending on the symptoms and so on. And I think that will give you about 90% of the information to say, actually, if I put your numbers into a risk score, you're going to be off the charts, and it's totally reasonable to consider aspirin. But as Herzl said, the 50-year-old exec, the actual risk-benefit ratio there, I think, is fairly neutral, and it's not the right therapy.
On the right here?
The SGLT2s have different grade recommendations. So we're just wondering at our table, the studies that have been done on the different brands, not to name them, did they look at the same adverse outcome profiles? Were the trials similar?
Well, maybe I can comment, and then David can comment for the heart failure signal. So there are certainly major differences in the clinical trial. So the empagliflozin and EMPA-REG outcome was all patients with established cardiovascular disease, and 1/4, in fact, had chronic renal impairment. The canagliflozin trial looked at it was 10,000 patients, and it had about 40%, 4,000 patients were in the so-called, even though I agree with Hertzel, we shouldn't use primary, they were in this primary prevention group, whereas it was about 60% or 10,000 patients out of 17,000 in the DECLARE trial. The reason the level of evidence changed is there was the amputation and fracture signal with the canagliflozin trial. So you can argue whether or not it's real or not. It was felt that the overall net clinical benefit, and if we're sitting in front of a patient and you're saying, if you're giving it for secondary prevention, should I give empagliflozin or canagliflozin, it would be remiss not to mention that there was this signal, whether or not you believe it or not, but there was a signal for amputation and fracture, so we need to describe that and discuss it with the patient, and that therefore, compared to an agent where we did not see that signal, lowered the level of evidence. Yep. The DECLARE trial looked for the amputation signal, as I think Herzl put the slide up, and they didn't see a signal in that trial, but there is some real world evidence suggesting that this is potentially there with all three agents, so it's confusing at the moment, and maybe...
Actually, I'd just like to expand on the amputation thing. Yes, there is this real world data, which real world data is subject to confounding, so I'm not sure whether it's actually true, but I think there's enough signal for us to be cautious. Patients are obviously very frightened about amputations. I think there's two issues. One is that patients with peripheral vascular disease have a very high instance of cardiovascular events. So we need to do what we can to reduce their events. So if you just have peripheral vascular disease, I don't think there's any reason for not using an SGLT2 inhibitor because the benefits greatly exceed the risks. On the other hand, if you have peripheral vascular disease and you have ischemic toes, blue toes, then I would not be using an SGLT2 in those patients. But just the presence of peripheral vascular disease and claudication, I think we should be considering an SGLT2 inhibitor in those patients because, as I said, the sub-study certainly of EMPEREG outcome in those patients had an enhanced benefit compared to the patients who didn't have peripheral vascular disease.
So I have a question, actually, that was handed to me from the audience, something different, but I think for Dr. Gerstein. If a pre-diabetic or a type 2 diabetic normalizes their blood sugars and HbA1c through lifestyle changes without medications, should their cardiovascular risk be considered to be that of a diabetic or a non-diabetic? And what's the need for tighter control of the blood sugar or treatment?
Yeah, so the answer to that question is we don't know with certainty. However, we know that from a number of trials, if you actually delay people going from pre-diabetes to diabetes, and this was one big trial done in in China about 25 years ago. If you delay development of pre-diabetes to diabetes, so they're still pre-diabetes, it's sort of indirectly answering the question, they have much lower risk of death 25 years later, and lower risk of eye disease and eye disease and death. Those are the two consequences, and cardiovascular disease 25 years later compared to not delaying diabetes. So delaying diabetes seems to prevent the consequences of diabetes. So then the question is, if you can reverse diabetes or regress diabetes, do you also prevent the consequences of diabetes? And we need to do that trial. For instance, right now, bariatric surgery very effectively remits diabetes in about 30 to 40% of patients. We don't know whether bariatric surgery actually prolongs life and whether that's related to the diabetes benefit or something else. So these are great questions. They need to be tested in the future. My suspicion is that if you are using therapy that normalizes people's metabolic state on all these ways and they're doing fine, then you've improved their underlying substrate and they're going to do better. But I don't have any proof other than just the indirect evidence that I've given you.
Question over there.
Just a comment first. The evidence informs our clinical decision-making?
Informs it, does not drive it. You're right.
Thank you very much for a life-affirming statement for family doctors.
That is totally true. No, in fact, that's published in the guidelines, in the Canadian Diabetes Association guidelines, not this version, but the 2013. There's a quote there, actually from me, which says that evidence informs your judgment, but does not mandate what you do. Absolutely, I totally say.
And my question was about heart failure that we're missing. An alarming thing to hear from a family doctor's point of view, so please enlighten me. So some of those early heart failures that I may treat differently.
Thank you. So it came as a big surprise to me that 27% of patients over the age of 65 had symptoms and validated heart dysfunction, which was called heart failure by a panel of heart failure experts. You know, there's a lot of patients with diabetes who complain of shortness of breath, unexplained. It's not always due to heart failure. So I think you've got this one precaution, I would say. If a patient comes to you and complains of new onset shortness of breath, think also that it could be related to coronary heart disease. So I would certainly send that patient for an echocardiogram to check out their heart function, but I might also consider doing exercise stress tests to make sure that the shortness of breath is not an anginal equivalent. But whether it's 27%, it's an important proportion of older patients who have diabetes who have unrecognized heart failure. And we need to be looking out for it, and it's not a bad idea to consider an SGLT2 inhibitor in that population.
Yeah, I think that, heart failure and ischemic heart disease are not like two different things. I mean, they actually are two different manifestations of underlying heart disease. Most people, I think you'd agree, who've got heart failure probably have some ischemic heart disease as well, and most people with ischemic heart disease have some diastolic dysfunction. So I agree with exactly what David said. Really, we need to have a trial where we're targeting both, like an SGLT2 inhibitor and a GLP-1 receptor agonist. And I am sure that that we would. Well, I'm not sure. We'd have to do the trial, but we would see that the two of them together are better than either one alone. So, I just think if somebody's got heart failure, they may have ischemic heart disease. Have ischemic disease, they may also have preserved ejection fraction heart failure. And so, right? I mean, that's fair.
Question over here.
Hi, I'm an internist who does a lot of obstetric medicine, and we haven't heard a lot about the management of our application of the diabetes guidelines to the young women who have type 1, type 2, and pre-diabetes. I'll editorialize the one population we should start aspirin in are these women when they become pregnant to prevent preeclampsia. But I was just wondering how you apply these guidelines in your own practices to young women of childbearing age.
Well, all of the evidence that was described today was not, pregnant women were explicitly excluded from every one of these trials, right? So, for all sorts of reasons, as you know, if you're doing obstetric medicine. So, and during pregnancy, there are two people that you're worried about with respect to the drugs, as you know. So, I think the most important thing from my perspective, who doesn't do obstetric medicine, is after pregnancy. So women who've had gestational diabetes, for instance, which is very common, those are the people that are red flagging themselves as being really high risk for all these problems down the line. They're the ones that need to be scrutinized and followed for diabetes and preventing the consequences of diabetes. And even if they have diabetes, everyone who's pregnant gets access to the system, and they should be flagged at that time for subsequent follow-up and management. But other than that, none of these drugs would be used in a pregnant state because they're not being tested in a pregnant state, with the exception of metformin and sulfonylureas. But insulin's totally safe in pregnancy. Metformin is safe. Sulfonylurea is probably safe. They're being tested as well, as you know. So that's it.
And asprin, which they should all take.
And aspirin, which
they should all take in pregnancy. The one group where we should do it.
They should all take, you're saying.
Yeah. Starting at 12 weeks gestational age, 15% reduction in preeclampsia.
Okay.
There is an entire section in the clinical practice guidelines that Diane wrote. It is a smaller area, but obviously it's extremely important. And I think it was the single one that had the greatest number of recommendations, because there's certainly a lot more evidence evolving in this area. But you're absolutely right. The ACE inhibitors, verboten. You certainly don't want to go near any of the other statins themselves, or really we don't have any data for any of the other antihypoglycemic agents. It's insulin. Yep.
Great. Thank you very much.
Question over here.
This is a comment. First of all, we're very happy to have 3 of you, or 4 of you who spoke to us this morning. Look at the audience. Everybody wants to hear more. Everybody wants to learn more. There are about 10 million people in our country with diabetes. But one thing we're not stressing enough is smoking. Smoking and diabetes, they don't mix. From the day they come to your office, let them know that. If they smoke and they have diabetes, the stroke, myocardial infarct, dialysis, they cannot escape one of them. They have to have at least 2 of them. So we're very grateful for all the speeches we have this morning, and we thank you for that.
Mm-hmm.
Yep.
Yes.
No, I think it's
very,
an excellent point.
Yeah, very important comment. I think we underestimate too of actually how many people still smoke.
Yeah, and even in these trials, every single trial, these are people who volunteer, who are consenting, and you look at every one of them, it's always the same number, 15%. 15% of all these cardiovascular outcomes are smokers. And to me, it's unbelievable. 15% in this day and age. Former smokers is like 50%, but 15% of people who are participating in cardiovascular outcomes trial still smoke.
And I guess at the moment we don't know the impact of marijuana, we don't know the impact of vaping and all other things, so it's going to be a watch this space over the next 25 years.
Well, yeah.
I know the impact of marijuana last night was a stink in my room, and it wasn't me smoking.
Sure.
That's interesting. I have a question here from the audience as well. Can GLP-1 agonists or SGLT2s be given safely with an ACE or ARB? Are there any contraindications?
All the studies have been, those have been background therapy in like more than, remember, these studies have been done in high-risk cardiovascular patients. And there's been, and all of these trials that were presented today, they were all designed that the background cardiovascular therapy should be optimized. So there was a push, they should all be on statins, and they should all be on ACE, ARBs, et cetera. So if you actually look at the papers, about 65% plus of all the participants in these trials in both arms, placebo and the active drug in all these trials, were on ACE, ARB or a statin. So the answer is there's no reason to not give them together. The only thing to keep in mind is, and this is something that people forget about, is that when you are taking these drugs and you get an intercurrent illness, like a bad intercurrent illness that makes you really dehydrated, you should probably hold your SGLT2 inhibitor and hold your ACE ARB, because you can get renal dysfunction, dehydration, et cetera, because both these drugs can drop your blood pressure, and those are the drugs that should be kind of held, and the nephrologists say this as well. What's their acronym? SADS or something?
SADS.
SADMANS.
SADMANS.
Yeah, yeah.
Because S is
that's right.
SGLT2 inhibitor.
That's right. So basically, these drugs should be withheld while they're acutely ill, until they get over their acutely ill.
So the other thing, which just talking about drugs in association, particularly with the SGLT2 inhibitors, you need to assess volume status and blood pressure before you initiate treatment with an SGLT2 inhibitor. So if your patient's on a diuretic, make sure that they're not volume depleted, make sure they don't have postural hypotension. If so, back off on the diuretic before you initiate treatment. Check their blood pressure. If their blood pressure is at all borderline, then you need to cut back on other treatments, for reduce the dose of ACE inhibitors, for example. An SGLT2 inhibitor will drop the systolic blood pressure by about 6 millimeters of mercury. So, if your blood pressure is already only 90, it might make somebody symptomatic. The risk of acute renal failure with an SGLT2 inhibitor is very low, and in fact, in the clinical trials, there are less acute renal failure patients on the SGLT2 inhibitor than on placebo. Even so, we need to be careful. We need to follow the sick day policy, which Herzl has told you about. We also need to check blood pressures when we initiate treatment.
Yeah. Maybe just one comment on that. There's David Cherney, who's a nephrologist here University of Toronto has done some absolutely fantastic mechanistic work in humans to show why ACE or angiotensin receptor blockers work with the SGLT2 inhibitors for nephroprotection. So there's a good rationale to actually use the two together, and there is a number of dedicated renal trials that we'll be reporting out shortly to get us a better understanding of this, how renoprotective these drugs are. It's very clear. We've seen the heart failure data David presented, but in the next year or two, a number of specific kidney trials, but there is a very good rationale, so I actually like to use the two together.
And actually, those kidney trials are going to be done in patients with and without diabetes, so we'll have more information on the use of SGLT2 inhibitors in patients who don't have diabetes.
I'd like to thank all our presenters for riveting presentations and unbelievable up-to-date information and discussion. Thank you very much.